that's my list. Looks almost as horrible as the one we had in ENT. A little bit shorter, but it's pretty much, none of these are things that are foreign to you guys, right? You're all very familiar with them. Oh, God. Not again.
We're really having an issue.
Did y'all drink this morning?
Shakes.
There are too much caffeine. Yes. So, first off, we'll start with the eyes. A pair of them, so don't forget when you're doing an exam to look at both of them. And generally, I look at the normal one first, then I look at the abnormal. But isn't that a cool picture? I really thought it was an eye. It's not. It's a faucet. It's great. Oh. See the bubbles, the swirling water? All right, the eyeballs. These are one of the most common things you guys will run into because everyone will call, do I have pink eye? My eye is red. Can you see me? You'll get tons of these every day. Now, the question is, how do you tell the difference between allergic, viral, or bacterial? Okay, we're getting ready to find out. Shuffle, shuffle. Quick Google it, anybody? 2 spades. Who has it?
Me.
Okay, Jessica. Yes. Or is it Jessica or Mia? Jessica. Yeah. Okay. Allergic conjunctivitis. What do you think that patient, or the parent, really not really the kid, but the parent will come in complaining about or telling you what their kid is complaining of for allergic conjunctivitis, signs and symptoms?
Eyes are watering, red, itchy.
Okay, that's good. And then what other symptoms may they have along with the eye symptoms?
Runny nose, cough.
Okay. Well, their discharge will be, what will it look like usually?
It'll be clear.
Okay. And will there be edema in their eyelids, you think?
Yeah, some, depending on if
If they're rubbing it, but generally very mild, if any, but most likely they wouldn't have any. Do you think you'd have any lymphadenopathy with an allergy? Okay. And then what would your treatment be?
allergy medication, maybe some eye drops for allergy eyes, and start a corticosteroid, probably nasal corticosteroid.
Mm-hmm. And you can also give them oral antihistamines too, like Claritin. Claritin, I think, are what is usually given for children, right? Did you guys have your, it's usually Claritin, how many milligrams? Anybody?
5. That's one of them.
2, we didn't
talk about Claritin. We talked about Singular.
We talked about Claritin.
Usually the children's dose is half of the adult, so it's usually 5 milligrams. Good job. See? It's all there. Plus you'll find kids. Okay. So you all understand allergic? So it's just like allergies. Someone comes in complaining of, they're all going to come in complaining they have a red eye, and they're worried about if it's going to be pink eye, right? So it's your job to kind of look at them, get a good history, and determine which one you think it is. Okay? So the next is viral. 10 of these. 12. Anybody? This one? Nobody?
Wait, I'm not getting cards.
You guys match. I don't know what they're called. They match.
What is this?
Yeah, that's the same.
Club. Oh, no, that was spades. Okay, let's see. I don't play cards.
Like, seriously.
This is why I don't go to the casino.
Don't play pitch. Everybody know how to play pitch? That's a hard game to learn when you're drinking on New Year's Eve. Okay. Viral conjunctivitis. What will this parent come in saying their kid is complaining about?
I think it was like the discharge. They have discharge over eye, they have redness and swelling and pain.
Yes. So with these, what would their discharge look like?
It'd be purulent, like green or whitish.
Anybody disagree?
Be clear.
Be clear.
I thought it's the one that's like thick and it masks there.
Well, but it's still usually clear. It looks purulent because it kind of gets matted up overnight. It's because it's a little bit more thick consistency, but it's still more of a clear, more maybe a mucoid if you want to say it that way. Okay. They will still have the red eyes. Will they have eyelid edema?
Yes.
Yeah. So this one with the viral, their eyes are pretty swollen. So eyelids are pretty swollen. And then, do they have lymphadenopathy?
Yes.
Yes. And where would you find that lymphadenopathy?
Yeah, I would assume like consular, maybe submandibular.
Preauricular. Preauricular lymphadenopathy. So remember that viral. And the most common pathogen for viral conjunctivitis. Okay. Working on some of those. You know, spades. Okay, do you know what the most common pathogen for viral conjunctivitis is?
I do not.
Anyone know?
RSV.
It's one of those, but the most common one is adenovirus. Oh! How do you back? Okay, and then so sometimes you can also get other viral pathogens that can cause viral conjunctivitis. What's another virus that's pretty common that they can get vesicles on their eyes? And Keely, how do you treat viral conjunctivitis?
Not antibiotics, because it's viral.
Correct. Supportive. Supportive, yes. Very good. Okay. Any questions about these two?
What would be how do you differentiate like signs, symptoms, and then associated symptoms for viral?
So for viral, the associated symptoms would they would have the lymphadenopathy, and they'd have more of the eyelid swelling. But they usually will all have the same. With the allergic one, they have more allergy symptoms, probably maybe a little bit of sneezing, itchy, watery eyes. The viral probably has more pain than there is actually itching. But they're both self-limited. All right. Acute conjunctivitis, so bacterial conjunctivitis. And So what would this parent say when they're coming and calling you saying their kid is sick?
My kid's got this nasty jump from out of his eye.
That's right. Kid is having pain, so the discharge is purulent. So this one, the discharge is purulent. The other two are more clear, watery. This one is thick, yucky, crusty. Will this have eyelid edema?
Yeah.
Maybe. I think all of them can have a little bit of eyelid edema, but just remember that the viral one has a significant amount of edema. Okay, so you can help differentiate that. Will it have lymphadenopathy? No. And then the most common pathogen. It's not the most common. What is it? What three go together? H flu, what? Yes. And you can also have staph.
So what are they?
Strep pneumo, H flu, and MCAT. So remember, those three always usually go together for all your head and neck. Usually if there's one, the other two is there as well. Those three, but actually H flu is actually the more common. But it used to be more common until we had vaccination. So on the pneumococcal vaccination, H flu used to be more common. And how do you treat bacterial conjunctivitis? Which ones? You don't give me a name, give me a class. Or give me a name. Is that easier? Huh? Erythromycin? Yes. Gentamicin, you could do like a little ribbon, they have it called ointment, but a ribbon of gentamicin, or you can do fluoroquinolone. Yeah. Okay.
Professor Brooks,
Yes.
is that the fluoroquinolones, are they topical at that point?
So you have like, I think there's Cipro, because you can do Ciprodex, which is for the ears. There's an Odic, Ciprodex, or Cipro, there's an Odic, and there's
You
an
don't,
ophthalmic.
you don't have to worry about the tendon side effects that you do with oil?
No, not generally, not for a topical one like that. So which one do you guys think this is? Mine, you too. This one? More viral. Look at his eyelids. You know, his eyelids are pretty swollen. He does have some crusty there, but again, he's probably slept overnight. It's been there for 8 hours. He just gets real, you know, dry and crusty. Oh, that one's bacterial. So that's really thick and goopy. So when they come in their office, you'll see it. Like I saw a kid with the sinusitis, and it's like he came in from his nose, it's all green, it's stuck. It's like the episode of Dumb and Dumber. It's all across his face like this. And so that's what happens. Kids like have a sinus infection or whatever, and they just wipe up to their eyes, and they get it in their eyes. What do you think that one is? I can't decide, allergic or viral. Because you can't tell if her lower eyelid looks more swollen than her upper eyelid. Okay, do y'all remember orbital cellulitis? And what's the most common pathogen? How do kids or people get orbital cellulitis? How? Yeah,
Is it the sinus?
From their nose.
sinus infections.
Can I ask you a question?
Yeah.
What was the bilateral, unilateral rule for viral, bacterial?
So usually, I think for the viral, it could be one or the other. Allergic is generally both eyes, because you're itchy, both eyes are usually involved. Viral could be one or could be both. Same with bacterial. Usually bacterial, you'll get it in one, and since it's so contagious and viral, it's usually in the other. So it may start out with one, but then by the time they come see you, it may be in both eyes.
On presentation, is it pretty easy to tell the bacterial versus the viral?
Mm-hmm. And by
In real
symptoms
life.
too. So make sure you get a good history from them. Okay. Yes, sorry, Jenna.
Fevers.
Huh?
Fevers.
Fevers?
That is with bacteria.
Probably with bacterial. I mean, you can have a low grade with either, I think any of them, but probably with the bacterial you might have a little higher fever. Just because they've had a bacterial infection probably in their sinuses or in their nose. They've had a sinusitis prior to that. 3 diamonds. Anyone?
What'd she ask?
Oh,
I don't know, Regina just said.
so, the patient comes in, mom says, my kid woke up today and his eye is swollen shut. Okay? They come in to see you, his eyelid is all red, his eye's all shut. What do you want to know what could have caused his cellulitis of his eye? Yes. Yeah, but what's the most common? Right, of which sinus? Maxillary. Okay, and then what's the most common pathogen? Huh? Yep, good job. And then what else can you have? Staph? What type of strep? Pyogenes. Group A, beta hemolytic strep. But staph is the most common one. And how would you work this up if you had to? You could, if you know, if it's depends on how severe the cellulitis is and how septic appearing the child is. But most likely, you would probably want to send them where? Where? Probably to the ER.
Yeah.
Because, what are the complications of orbital cellulitis? What are you worried about the most? Eye, vision loss, what else? Where can it go? The brain. So you get a brain abscess. And also, what else can it affect? Like nerve-wise. Facial. And then you can also develop a bacterial meningitis. Okay? And then, what would you treat them with? That go where? How are they administered? So this little boy on the left, yes, he obviously has signs of cellulitis. So that's what an orbital cellulitis would look like. So that looks really scary, right? Kid on the right, he also has orbital cellulitis. But what happened with him is sometimes a tumor of the eye called, anybody know, pediatrics? Can present as orbital cellulitis. Retinoblastoma. Because once the tumor necroses, it causes secondary inflammation infection. So if this kid, you admitted him and you put him on IV antibiotics, the redness and the infection goes away, but the swelling is still there, then you might want to image him. And they did, and he actually had a tumor of his eye. Did I already do this one? You 3 diamonds? You were 3 diamonds?
Yes.
Some questions about that?
Wasn't there something about like if it stays contained, like within their orbital socket, or just like if it moves? I remember talking about something.
So adults, I think adults you can generally treat outpatient. You know, for children, you have to be a little more cautious, and I would send them to the ER. But any time I've ever had an orbital cellulitis, I sent them to the ER because I didn't want to take that risk. We actually had a patient that had she had a sinus infection, and you know, I'm sure she's had it for a while, didn't think thought it would just kind of go away. Well, then she ended up getting sicker, and she actually got meningitis, and she had to be hospitalized. So my attending we walked in, I'm like, hey! Thank God I didn't see her, but she was fine, she survived. And you guys all remember strabismus, right? And three of clubs. See one?
Your space.
Yeah, club has that one. Are your spades or clubs?
I'm club.
Okay. Strabismus. So what is strabismus?
It's where you have one eye that is not centered and focused, and the other one is it kind of like goes to the side or.
Right. So they're not looking at the same planes at the same time, right? So what would can you think about how your patient would present? What would the mom say about their kid?
Maybe that they've noticed that the eye is not focusing with the other one, or maybe they're a little bit more clumsy or having issues focusing.
Okay, good. My friend's kid had this, she called it his gotcha eye. I don't know why she called that, but he actually had surgery on his gotcha eye. So, are there any risk factors for kids who have strabismus?
Sure, I know it.
And it's usually due to what?
Muscle weakness around the eye.
Which cranial nerves?
Good.
Good, you. Now, do you know what esotropia, exotropia, hypertropia, and hypotropia mean?
Well, you break the letter apart.
This is your midterm quiz right here.
So,
So the tropia means when they have both eyes open, that you can see the defect. The phoria means only when the eyes get covered. When we do that cover test, so that's phoria. It's the same thing. But with the tropia, you can see them when you're looking at them without having to cover their eye. Okay. And then, Jack and Plus.
Yeah, that's me.
Which, if someone were to suffer, a kid were to suffer a blowout fracture, which of those 6 up there would you most likely see? 8, I'm sorry, 8. Can't count. Because where blowout fractures usually occur? The floor of the orbit, right?
Right.
So what would you generally see if a kid comes in, mom says he was hit by a baseball bat yesterday, or ball?
They're not going to be able to look down. Is it that or,
Yeah, what direction?
Which direction would their eye be pointing?
oh, which would they be? Would be.
Just think about it. So where would the nerve get entrapped?
Down.
Right. So their
They'd be
eye,
pointing.
yeah, their eye would be pointing down for blowout fracture. So it would be hypotropia. And then you guys know how to diagnose it, right? You do a cover test. And how do you treat it?
Well, obviously, if it was a fracture.
Well, no, it's just registered business, just in general.
You have to strengthen the eye, so they do like the cover glasses.
Patch.
Patch, yeah.
Did you all know Professor Hughes wore a patch? I wanted to get a picture for my this presentation, but she wouldn't give it to me.
So don't you cover the good eye?
Yes.
How you good eyes?
Yes. So it strengthens the bad eye. And then obviously you can also have surgery to the cranial nerve muscle. Cranial nerve. The muscle. Whatever. These poor babies. Who does that look like in that ear? It's a dog ear. Have y'all seen that? They were floating around Facebook forever. And I was like, oh my God, it's a dog's ear and it looks like Donald Trump.
Oh, you see
You
it?
see it?
All my songs
It's even got the hair, it's got the hair stuff in there. Any questions about the eyes? I thought this was just really funny. Front ear. It's like a bad dad joke right here. But it's so good.
That's like the part of it, you know, you don't need to say that.
Front ear. Anybody watch Star Trek? Is anybody Star Trek fans in here? Okay. This is probably the most common. I already said you had a lot of eye complaints, but this is the most common thing you all will see in practice is ear pain. Okay, and this is the most common disease you'll probably see in children. About 50% of children will have one infection by the time they are 1 year old. Okay, does anybody know why? Right. So, signs and symptoms. Hold on. I gotta do this faster because we're running out of time. Queen of Spades. So what would your mom, so mom says, hey, my kid
Has their ear hurts.
their ear hurts, right? So what other signs and symptoms could they have?
Well, if you look at the ear, you're gonna have bulging of the tin, and it's probably gonna be really red. You might see some like pus on the inside, some white. You wanna look like behind the ear to see if it hadn't moved to the mastoid, stuff like that.
And would you have increased mobility or decreased mobility of the TM?
Decrease.
Decreased mobility, good. What risk factors?
They swim?
No.
Oh, no, yeah. Oh, yeah.
This is behind the eardrum.
If they have drainage or anything?
So if they've had a previous infection like a URI or cold. What else? Like environmental factors. Think about environmental factors.
Environmental. Allergies.
Allergies.
Anything that can like drain on the inside of the mouth can go into the ear.
Right? Or they can have eustachian tube dysfunction, so allergies. If they are in a daycare kids have a lot of,
Forget about the
daycare children, and also those who live in a smoking household. So what decreases the risk? Oh, there's one more. Big one for is bottle feeding. Bottle feeding, daycare, and smoking in the home are big risk factors for otitis media. Because a lot of times what you just lay your baby back and you prop a bottle in, let them go night-night, and it just drains straight back, and it just sits there, okay? So what do you think will help decrease the risk of ear infections in children? Breastfeeding, because you're only giving a little bit at a time, they're sucking, and then what else? I kind of already said it earlier.
Don't go to daycare.
Yes, don't go to daycare, and don't smoke. But a pneumococcal vaccination. Which leads me to what's the most common pathogens of acute otitis media?
The same strep pneumo and
And what?
the H.
Okay. And treatment of acute otitis media.
Probably do antibiotic like erythromycin and.
What's the first line for acute otitis? Amoxicillin. Augmentin we usually say for resistant bacteria. So if your kid, you give them amoxicillin, they go home, 48, 72 hours, mom says they're not any better, then I would switch to Augmentin. Because what's one of the big side effects of Augmentin for babies, kids? GI, so they get diarrhea, and they get stomach pains. So I would start off with amoxicillin. Anybody know the dosage for pediatric amoxicillin?
That's the high dose. It's 90.
80 to 90 mg per kid. Good job. And this is always, because majority of otitis media in children are going to be viral, right? So the question is, when do you treat them with antibiotics versus when do you let them see, observe and see how they do? In general, for kids that are less than 24 months old, you'll treat them with antibiotics. Older children, you can give it 48 hours, bring them back, or tell the mom to call you in a couple days and see if they're not any better, then start them on antibiotics. Because worry about in children, because anytime if you guys work in an urgent care, those parents are going to come in and they're going to want antibiotics for their kid. That's just how it is. I'm paying my $50 and I want antibiotics. But if you can educate your parent and let them know, this is why I don't want to do this, we'll see how it goes. And older children, you can do that. But kids under 2, go ahead and treat, okay? And so there's a picture. All right. And then we have something called recurrent acute otitis media, which I don't remember if I talked about this in ENT. So basically, these kids have 3 episodes, greater than 3 episodes within a 6 to 12 month period. Okay? And they'll have periods where they're fine, get better, completely resolve, and then they have another infection. So back in the days, they used to give antibiotic prophylaxis for these kids. But you know what happened? Resistance. So if you decide, if you've had a kid that keeps getting ear infections over and over and over, and you want to try them on antibiotics, no more than 6 months duration, okay? Don't give them, because then they start to get resistant to it. And what vaccine did I say earlier? Okay. And then surgery. So these kids, if you see a kid keeps getting ear infections, then if they're not able to resolve with treatment, then I would send them to an ENT. Okay? Then they can put tubes in their ears to let it continue to drain. Anybody have tubes as a kid? Most of you guys know the pain of your, well, you probably don't. You
Shocker.
And then there's otitis media with a few effusion. So that's basically an eardrum or fluid behind the ears without infection, it's just inflammation. So I kind of wrote it up there. How do you get this? Usually if you've got some type of eustachian tube dysfunction. So something is blocking and keeping those things entrapped in there, the fluid back there. Or if for an adult, if they go fly on a plane, that negative pressure, people can develop serous otitis media with that. So what kind of symptoms would you expect in children? 3 of spades. Okay, so what, if you had a kid who comes in, their parent says, my kid has ear pain, right? What other things would they complain about as well in a kid, would you think?
Fever maybe?
No, because it's not infection. It's just fluid. It's just, just fluid behind the ear. So they probably wouldn't have infection.
Maybe positional pain, like lying down, waking up?
No, probably not as much. With this, they've just got fluid back there. So if you got,
Serous effusion?
yeah, you've got a serous fluid effusion behind the eardrum. So what kind of hearing loss would you expect? Would you have any hearing loss? How many say conductive? So remember, conductive just means that there's something that's blocking sound from getting into the middle ear. So fluid is in the way. So it would be a conductive hearing loss. So your kids, most of the time kids are not symptomatic. They may not even know that, other than they may just tug at their ear or complain that their ear feels full. Okay, Jenna, do you have a question?
What's the other kind of conductive and the nerve? What's the nerve called?
Conductive would be like earwax.
But what's the other one
Oh,
called?
sensorineural.
Sensorineural.
Can this cause tinnitus?
Huh?
Can this cause ringing in the ears?
Generally not. Ringing is probably the sensorineural hearing loss. So in children, they're most likely not going to be asymptomatic. Adults, however, will complain of fullness in their ear. They may hear popping, clicking of the ear, those kinds of things. Now, a lot of times these kids will have allergies, so that's why they have an effusion in their ear. Most times it's going to be bilateral. Some can have it chronically. With adults though, so don't forget, an adult who has an acute or immediate acute episode of unilateral serous otitis media, you need to make sure they go get seen if it doesn't resolve, because you're worried about what? Don't remember that? So how does one get fluid behind the ear? Something's blocking it from draining, right? Blocking the eustachian tube. So an adult with a unilateral serous otitis media that's a new onset, what were you concerned about?
A tumor in the
A
side.
tumor. What kind of tumor? Nasopharyngeal tumor. I think I put pathogen in here, but I really don't need to. Because usually it's viral. A lot of times, or it's due to some type of eustachian tube dysfunction, something blocking the way. And what would the ear usually look like when you're looking at it?
It's bulged, kind of behind.
Huh?
It's bulged, like the nodes are like swelling.
Shouldn't be any nodal swelling because it's not infectious. It's just fluid behind the eardrum. So usually these people, you'd see an air fluid bubble. It could be amber in color, like a yellowish color. Sometimes it might be mucoid, looks a little bit like snot back behind the ear, because a lot of times those kids, it is drainage from their nose that's sitting behind their eardrum. Okay? And then, would you expect what would the membrane, what would the TM look like? You said it could be bulging, right?
Yes.
What else?
Bulging with effusion. Bulging with effusion.
Right,
Maybe the color changes some of the J membrane. It's not pink anymore.
right, but what would the TM look like if you're looking at the membrane itself? You know, if it's bulging, it can also be bulging, but it can actually look normal with fluid behind it, or it can be retracted. So it'll be sucked in, and you'll see the bones of the eardrum really well. With the otitis media effusion, you can see all of those. But you're looking for the fluid and the fluid levels and the bubbles behind the eardrum. Okay. And how do you treat that?
Amoxicillin, 90 milligrams per kg per day.
Well, usually with the effusion, you would give them, well, for adults, I would give them a short course of steroids. You can do oral steroids or the nasal steroid. Because basically there's not an infection, so you wouldn't give them antibiotics. You know, what you're doing is you want to decrease that inflammation around the eustachian tube to allow the middle ear to ventilate.
Do we do anything to clear the effusion first before we give the steroids?
So if it's longer than 3 months, if this kid still has fluid behind the ear, then you would send them to an ENT. And what would they put in there? Tubes. Okay. And then also, what else can block the opening to the eustachian tube? What's back there? What is that?
Cerumen can block.
What also can block the opening to the eustachian tube? If you kind of think in your brain, if I'm sitting a scope down the nose, what sits back there in the posterior pharyngeal wall? Tonsils, also, and adenoids. So you can also send them for tonsillectomy and adenoidectomy, or TNA is what they call them.
So would you do steroids for kids as well?
Yeah, oh, you could do I'd have to look at the dosing for children, it's been so long, but yeah, you can do steroids for children. So just be more cautious of them. I would, you know, steroids, nasal steroids are probably hard to put in kids, so probably just a short Medrol. I don't know if there's a pediatric dosing for Medrol, but for the adults it's 4 milligrams. So see how that first picture kind of has that amber look to it? And it's kind of hard to see, but in the middle one you can see a small little air bubble at the top. It's a little bit retracted up there, but that's what a tube looks like in the ear. So when you guys go looking in ears, they can vary in color, they may be white, but the majority of them are going to be blue. Sometimes I've seen green. I don't know if anybody got to look at a tube. No one, has anybody seen it? Yeah, so unless you're around children or have children, you most likely wouldn't have seen these. And then a complication of acute otitis media is tympanic membrane perforation. So what happens, you get too much pressure behind the eardrums, and the eardrum is the area of least resistance, so if it goes out that way and too much pressure or fluid behind the ear, it'll pop a hole. Or someone decides to slap you on the face. Or we saw this a lot was you go water skiing, fall off your water skis, slap right into the water, perforate their ear. I saw that one a lot. So risk factors the same. You've had an acute otitis media, you've had acute otitis media with effusion, those are risk factors, or like we talked about earlier, trauma, barotrauma. How would you work this out? You look in their ear. Okay, you'll see the big old hole there. Sometimes they're kind of small and you can't really see them, but then you have to listen to the history of the patient and then take a really good look in their ear. How do you treat these? These are usually self-healing. They usually will heal on their own. But a lot of times if they don't, then you can send them to a ENT and they'll do a tympanoplasty. Yes?
So with these, I've heard it both that like you don't hear anything or that everything is really loud, like in your eardrum.
most of my patients that I had didn't really complain about much of anything. They could have a hole there. I think one of our students has had a hole in his eardrum forever. He may have a little bit decreased hearing loss, but he didn't complain about things being louder, that I remember. Yes.
So I have shoulder perforation in
Uh-huh.
my right eardrum and tons of scarring on both. And I never had tubes as a kid or anything, like I saw a lot of ear infections, but
Right.
I don't really notice anything different.
You don't notice any noise, any loss of hearing or things being louder. So with a TM perforation lasting this long, what is one of the complications that you could have for heart?
Vasculitis or some other sort of infection back there.
Yeah, you could.
Or hearing loss.
Uh-huh. But what else? So you've got a hole there. What can creep into that hole?
Well, I did find my ear the other day, it freaked me out.
Well, hopefully it won't sit in there, but with long-term, a hole that's open, what can, all the debris in your ear, and then you can develop a... It starts with a C.
It's my favorite word.
April's got it, you should have April.
Cholesteatoma?
Cholesteatoma. Now here's another one. Where is it usually located if you have a perforation? Where is the most common place for cholesteatomas to develop?
Posterior,
Uh-huh.
up and to the back.
What area is that called? Do you remember? The pars flaccida. Yes.
Certain things.
What do they come in and complain about?
Usually people don't, like you said, people may not know they have one.
Okay, so it's just kind
It's
of
just,
like a-
yeah, a lot of times it's found incidentally, or it's usually after they've had a bad ear infection, you're following up with them, or they've had an accident, you know. Have you seen those videos of people, like, it's called the slap tournament, when they slap each other in the face?
Caitlin Shaw saw one.
When we went to those MMA fights, this guy's eardrum was literally like falling out of his ear.
Yeah,
Hips was
like
like,
with a cup.
doing it like suction cup it.
Yeah. It's horrible. I was like, why would you want someone that's going to just slap you in the face?
It's like a competition in Russia.
Maybe I saw, because I saw it was on
You're
Facebook,
not
I was like, you know that eardrum is
You're not
burst
sober
in
when you
their
do
head. So, like Caitlin said earlier, common side effect of acute otitis media is acute mastoiditis. This is very common. Sometimes kids who have ear infections don't even know, all of a sudden their mom sees the kid complaining of pain behind their ear. It's all big, red, and swollen. Joker? What's the most common pathogen of acute otitis media? Mastoiditis, sorry.
Staff. No.
Strep. Which one?
However you say it.
Iogenes.
Yeah.
So group A strep. But you can also get strep pneumo, H. flu, and then sometimes you can also get Pseudomonas that causes it as well. Risk factors for acute mastoiditis. Obviously, you've had an ear infection. How would you work this up?
Look at it.
And
Pull on the
pull on the mirror. Probably wouldn't like it very much.
push back here for anything.
But you could treat them, but you could also do a CAT scan. That's give or take, whether or not you want to do CT scan of the temporal bone and see, you're giving your patient radiation, but obviously if it doesn't get better, you'll have to do a CAT scan. So with these people, you can treat them. A lot of times you might want to have to put them in inpatient, for especially children, because they'll need IV antibiotics. And a lot of times these patients, you may have to put tubes in their ear if they don't get better. Can't get that infection to clear. I had a friend of mine, her kid, he had an ear infection, she had no idea. All of a sudden he's got this sudden onset of high fever, redness behind his ear. She takes him in and they admit him, put him on IV antibiotics, the redness goes away, they send him home. Within 24 hours, his fever spiked again, it got red again, so she had to go back to the ER. They readmit him, they planted a tube in his ear, gave him IV antibiotics, and then eventually he finally got better. Yes?
For all of these, how do you tell the difference between an ear infection or something of that matter and like teething babies?
And what?
Like teething kids? Like don't, when kids
So
teeth,
kids,
they
yeah,
get
right, so you look at their symptoms, right? Do they have a fever? You know, do they have a runny nose? You know, if they're screaming, so it's kind of hard when kids are screaming and crying, it's hard to tell if it's an ear infection. But again, most of those can be babies. So a lot of times these babies have had a cold, have snotty, runny nose, and you look in their ear and it's bright red, they've been crying. It depends on your supervising physician. My pediatrician would never give my kid an antibiotic, even when she was a baby. So he would give it 24 hours, 48 hours, and see how she would do, and then he would maybe call in something. But most times it was viral, she got better. But as a general rule, if they're under 24 months, I would treat them. So if you see it red, I would err on the side of caution, because you could develop a mastoiditis in that baby, and you don't want that. So sometimes it's hard to tell the difference of viral versus bacterial. Look at their symptoms. Now, acute mastoiditis, they have a high fever, pain, swelling, redness, that kind of stuff. And they'll tell you, yeah, they just got over an ear infection or have been sick, that kind of stuff. So usually those kids, their ear will stick out because it's so swollen back there. That poor baby. They look miserable. And they can do a simple mastoidectomy, so they would cut through the mastoid bone, clean out, debride all that bone, because basically mastoiditis is, by then you're getting osteomyelitis of the temporal bone. And this is what it looks like on the CT. So you see that pocket. CT scans are hard to read. Did you all ever have a how to read CT scans?
It's like you're standing at their feet looking towards their...
Right, and a lot of times, you know, it's just a slight little movement and it changes all the windows. You're looking at different ones. But a lot of times you'll just learn that while you're on rotations, how to read one, or how to look at one. I didn't even learn really until I was working in head and neck. Okay. Oh my gosh, I believe we just got to ears. All right, do y'all need to break real quick and then we'll just finish off. Take a break.